Hello, everyone, and thank you so much for joining us today for our keynote speaker for the Inland Northwest Research Symposium. We apologize for the delay in starting. We are connected now, we're ready to go, and we'll be sure that we leave enough time at the end of the presentation to answer any of the questions that you might have. My name is Celestina Barbosa-Leiker. I'm an associate professor in the College of Nursing and vice chancellor for research at Washington State University Health Sciences Spokane. We've had a very eventful morning for the 2021 Inland Northwest Research Symposium already. We've had 29 research presentations this morning from all kinds of, with all kinds of health sciences backgrounds. It's been absolutely fantastic. And we have about 10 more presentations after our keynote today. So we'll come back at 1:30 for those research poster presentations, and we'll end today at about 3. So I just want to reiterate that we've been very impressed with all the research that we heard about this morning. The Inland Northwest Research Symposium started in 2005 as a way for interdisciplinary programs to highlight current research and innovations in the health sciences. We first started at Spokane and expanded to other communities and universities. We saw already this morning EWU, Heritage, and Pacific Northwest University, as well as some businesses from SP3 Northwest. So it's been very great. We're excited to continue this tradition, an annual event. And since we only have less than an hour here, I want to get right into introducing our special guest and keynote speaker today. It is my honor to introduce you all to Dr. Erica Austin. She is the founding director of the Edward R. Murrow Center for Media and Health Promotion Research in the Edward R. Murrow College of Communication. She served as Washington State University's Vice Provost for Academic Affairs from 2013 to 2019. Dr. Austin is internationally recognized for her research and outreach on how media literacy and parent-child communication about media contribute to decision-making about health and civic affairs among children, adolescents, and young adults. She has served as an advisor at the state and federal level on media literacy and health communication campaigns. Dr. Erica Austin has over 90 published articles and chapters on health promotion and media literacy. She is also an adopted Cougar by the WCU Alumni Association and the proud Coug mom of a 2018 WCU graduate. It is my honor to introduce you all to Dr. Erica Austin. Erica.
Thank you so much, Celestina. I'm excited to join all of you today and share some of my research as part of the Inland Northwest Research Symposium. And I want to congratulate everybody else who's been presenting today. It's been quite a day of research with more to follow. And one of the things that I've been discovering throughout my career is the more you know, the more you have to learn. And it's so exciting to be able to learn from each other. And this is such a great day to be able to talk about vaccines and disinformation, the role that they play, given that this is April Fool's Day. And the last time I did a major presentation like this that was so important to me on April Fool's Day happened to be when I was presenting to all of the chairs and directors at Washington State University about the incredibly important topic of student success, how we can make sure that students who come to Washington State University can be successful and that they can graduate. And just as I was getting ready to start that presentation, I had gone into the restroom just to make sure everything, I looked okay. And I got a call on my cell phone from my older son, not the one who just graduated a couple of years ago from WSU, the other son who was studying somewhere else. And he was playing in a band. He's a musician. And he said, Mom, I've just decided our band is doing so well. I have decided, even though I only have 2 quarters left to study, I'm going to drop out. I'm just going to go and do this band full time. And of course I was freaking out, and I tried to sound like the really calm mom. And I said, we really should talk about this. Maybe we can get back to discussing this later, but I have to go do this presentation. And he said, oh my goodness, you really believed me. April Fools. So it just goes to show how easy it is for us to get taken by people who are giving us disinformation on purpose That son, I'm happy to say, has graduated and he is a professional musician now. So I'm going to share my screen and I'm going to talk about some research related to disinformation and vaccines. So I think you can see this now. And so we're talking about healthy behaviors and vaccine uptake amidst COVID-19 and the disinformation, misinformation environment we've all had to navigate, mostly from our homes, right? So what you're seeing on the screen here is an image from the CDC, which is really, of course, trying to promote vaccines. And I'm happy to say there was just an article published this morning about how Washington State is really in the lead in terms of people's willingness to get the vaccine, but we also still have a long way to go. I want to acknowledge the research team that has been working on this with me. This is a multidisciplinary group, and I'm so proud to be part of this group. And I want all of you who are graduate students to know that this whole thing got started because of one of our graduate students in Murrow, and that is Sean Domgard. And I want to really give a shout out to him for motivating us to do some research. As soon as things started shutting down, he said, you know, I've been studying with you and this other professor, Jessica Willoughby, and I think it would be really neat if we could do a study together about COVID and information and what's going on. So we started doing this and we started getting other people involved, and lo and behold, we ended up having this wonderful research group. And we were looking mainly at this problem. People were making life and death decisions for themselves and also decisions that were going to have an impact on others amidst what was quickly becoming an infodemic amidst the pandemic. You'll notice these slides have links on them, so if you want more information afterwards, you can actually link to the presentation and then link to all of the background information, which is a really important part of being media literate, which is something that we really want to promote. This research group has done 2 different surveys. We're thinking about getting a third going now. But the 2 we did were back in April when things had just shut down. And then again in June and July when there was a lot going on in terms of social justice protests and things like that. So we knew things were changing and we wanted to see what things were changing and what things were not changing. You can see a map here of where our respondents came from for wave 1 and wave 2. And I want to thank Ofer Amram for creating these maps for us. He's a member of our team. And I also want to thank everyone who helped us fund this study so we could get it off the ground really quickly. So we really were looking a lot at this issue of media literacy. How can it help us manage this uncertain environment that often also has a lot of really toxic misinformation and disinformation that we have to sort through? And so we were looking at media literacy, which is the ability to access, analyze, evaluate, and create media in all of its forms. This is not just news. This is not just social media. This includes entertainment, movies, books, posters. As you're driving down the road, you see bumper stickers on people's cars and trucks, everything that is a created message. You can see here that the World Health Organization, WHO, became really concerned about the infodemic that was going on. And so they held an infodemiology conference midway through last year to try to deal with this topic and fight back. So this is just an example from last April to June, around the time we were doing our surveys, of just how much toxic information was circulating. And this is just an article about Facebook, which said it had taken down a ton of posts for spreading coronavirus misinformation. As it says here, they'd also labeled 98 million posts with warning messages. This is from a study in which the Reuters Institute looked at just how much misinformation was increasing in the media internationally. And they looked at how much it was increasing, and then they also looked at some of the topics that the misinformation and disinformation were focusing on. These are, this is their tracking. They essentially did a content analysis of a sample of the messages that were circulating around that time. And they were looking at the ones for which there had been fact checks, the ones where someone had called out the fact that this was misinformation or disinformation. And I should mention, misinformation can be something that is just, it's just a mistake. There can be some confusion, or as we all know, we've been learning as we've been going along through this pandemic, so information changes and some people might not be up to date. Disinformation, though, is shared purposefully, and it uses principles of psychology and persuasion to try to mislead people. So they were looking at both misinformation and disinformation in this sample. And what they found was that these were the most common themes in the misinformation that they were seeing. Messages could have multiple themes in them. And so if you were to add this up, it would add up to more than 100%. And that's why. They found that a lot of this misinformation was basically coming from us, people who are on social media, people who are talking with each other through social media. And so prominent politicians and celebrities and public figures are responsible directly for only 20% of the misinformation that was circulating, but they were motivating almost 70% of it. So people were retweeting and sharing on Facebook and that kind of thing. One of the things that was really difficult and continues to be really difficult about the misinformation environment is that they often include elements of truth. And then those elements of truth are packaged in things that are not true, or they are somehow manipulated in a way so that they sort of suck you in. You think, oh, I recognize that fact. And then they tell you some other things that aren't so true. So disinformation really, it's a malevolent thing. It's often organized by political actors. This is an article that was recently published in the Wall Street Journal about this issue, saying that there have been Russian disinformation campaigns aiming to undermine confidence in the COVID-19 vaccine. So it isn't just innocent actors. These are really planned disinformation campaigns. So in response to this infodemic that had really ramped up last year, and there were already concerns about misinformation circulating, but then it just went wild during the pandemic. So the World Health Organization launched a response last summer saying that an infodemic cannot be eliminated, but it can be managed. They started tracking the different topics that were circulating, and they tried to develop public service announcements, a campaign to promote good information. Misinformation can circulate more freely when there's a lack of good information, a lack of clear information, a lack of consistent information, when it's difficult for people to access good information. They take advantage of this. So this is a list of some of the topics that they saw circulating and for which they tried to circulate good information. So here's an example of misinformation, something that, just because people were getting confused. Antibiotics are important. Antibiotics sometimes are used when people are hospitalized, but antibiotics do not work against viruses. So they promoted the fact. One of the things you have to be careful about when you're trying to correct misinformation or prevent it is you don't want to accidentally amplify the misinformation or the disinformation. And so what you see here is that they're asking a question and answering it, but they aren't saying, by the way, we really want you to, they're not emphasizing the wrong message. They're trying to emphasize the correct message here. As you can see at the bottom of the slide, in our surveys, we also asked people about this issue. And what we found was that the people in April who understood that antibiotics cannot be used to treat the coronavirus was about 50%. And in July, it was a little bit higher at almost 55%. So people were learning. And these were representative national surveys. They were not phone surveys. People tend to not answer the phone anymore or answer surveys that way. This was done through what's called a opt-in panel survey that was representative in terms of different census kinds of quotas that we put around our sample respondents so that we could make sure we had people from different areas of the country and from different kinds of backgrounds and that sort of thing. Here's another example of misinformation that was circulating about garlic. Now, garlic can be very useful. It can be very good for you, and a lot of us really love eating garlic, but it's not going to cure or prevent the coronavirus. Those in our surveys in April who understood this were at about 59%. In July, actually, more of them had learned that garlic is not going to cure the coronavirus. These were two separate samples, but they were both representative of the country. People also were started out a little bit confused, right? We're still very worried about how deadly this virus can be, but most people do recover. The people who understood this in April were at about 69%. By July, that had increased to about 80%. Disinformation is a tougher issue, though. Can you inject bleach? No, you should not be injecting bleach. You should not even be rubbing bleach all over your body. And so they created a public service announcement about this. You can see in our surveys, there were people who were confused about this. This was from our second survey in July. And you can see that there were 23% who were unsure about the right answer to this question, whereas 18% actually believed that you can use bleach to treat COVID-19. A really, really dangerous thing to believe. It's also a dangerous thing even to be confused about. 5G networks. 5G networks do not spread COVID-19. You can see that in our survey, 25% actually believed that 5G networks can spread it. Another 28% were confused. This is dangerous. Hand dryers. Can hand dryers cure? No. There are some things to know about heat and killing germs and viruses, but you're not going to use hand dryers to treat COVID-19. Almost 25% of our sample believed that you could, and about 32% were unsure. So we need to think about how are these disinformation campaigns potentially affecting people's belief that they should get the COVID-19 vaccine? How much does knowledge contribute to that? These are really complicated issues as it happens. In July, we asked whether people were willing to get the vaccine in the future. It hadn't been created yet. There was a lot of uncertainty about it. As you can see that about 56% of our sample in the US said they were likely to get either likely or very likely to get the vaccine when it would become available. And in Washington state, we were pretty much ahead of the curve there. About 72% they were likely or very likely, extremely likely to get the vaccine when it became available. There was some survey data that was just announced today. You may have seen the news reports. Washington state is among the top 3 states for people's willingness to get the COVID-19 vaccine now that it is available. But we still have a ways to go. There's still a lot of people who aren't willing to get it, and we need to get to that level that helps us achieve herd immunity. This is what Americans' likelihood to get the vaccine looked like in terms of it evolving over last year. The ICF did this survey a number of different times. They did a tracking survey, and what they found was that Americans' willingness to get the vaccine was higher in May than it was in September. And so there was a lot of confusion, a lot of uncertainty, and a lot of mistrust that was developing. And the disinformation flow is continuing. This is an article from March of this year looking at a Facebook study about people's doubts in vaccines, essentially being traced back to a small group that was doing a lot to push disinformation about COVID-19. And you can see this story from the New York Times that just came out within the week about far-right extremists moving from stop the steal on the election to stop the vaccine. They've been taking advantage of this website, which is provided by the government, the Voluntary Adverse Event Reporting System, which collects data about people's reactions to vaccines, not just the COVID-19 vaccine, but any vaccine. The problem with this website is it provides raw data. It's not interpreted, but it's open access. Anyone can get to it, and in fact, anyone can contribute to it. It's a voluntary and self-reported system. And as you can see here, it collects data on any adverse event. So you can write in and say, I got the vaccine and I had this horrible reaction. You can write in and you can say, my grandparent got the vaccine and died. You can write in and say, my friend. You can write in anything you want and get it into this system. And so there's no verification about whether the information on this site is actually real, or whether there's any actual real causal association between the vaccine and whatever these events are that people are reporting in. And so disinformation campaigns are seizing on this to create confusion and mistrust. So the United Nations has been encouraging crowdsourcing to try to combat misinformation. If you're interested in getting involved, you can actually go to this website, shareverified.com/en, and you can get involved too. The World Health Organization is encouraging people to report misinformation that they come across. And you can go to that website and do help with the crowdsourcing. And the World Health Organization also has helped encourage media literacy. This is where I started in this presentation. The idea is that you need to stop and think before you accept information and before you share it. So before you share, think about who made it. What is the source? Is it a credible source? Where did it come from? Is it clear what the original source was? Why are you sharing it? Is it because you're being emotional? Maybe you should stop and think about that. When was it published? Is it current information? We are learning a lot. We're learning it quickly. So you want to make sure that what you're sharing is up to date. So how important is media literacy for COVID-19 decisions in particular? We've seen through lots of research that media literacy can be helpful for people's decisions. It can be helpful for health decisions in particular. In these studies with these data, we were testing its associations with how useful people considered government health organizations to be, and scientists and medical professionals like a lot of you who are listening right now, knowledge of COVID-19 facts, and people's intentions to get the COVID-19 vaccine. We also asked about some other issues, but this is the data that I'll be sharing with you here. What do I mean by media literacy? We look at media literacy for both sources and for content. When we ask people about the source of information they are looking at, we can ask about news, entertainment, advertising. These are the questions that we asked in our survey about sources. So who created it? Why did they create it? How can you be so sure that this is a credible source? We then ask questions about the content. So do you compare the content that you see in one news story with other content? Do you sort of cross-check to make sure that what you're seeing is consistent with what other sources are saying? Because if it's not, maybe you need to look into it a little bit further. You need to think twice about what news messages are telling you and consider whether it's accurate and up to date. So how can we apply all of this to vaccines? The World Health Organization did a lot of work on this, and they published a paper in 2014 in which they said there are basically these 3 C's we need to think about when we're trying to promote vaccine willingness. We need to manage people's expectations of risks and benefits so they won't be complacent. They'll actually be interested in getting the vaccine. We need to increase their confidence and reduce mistrust and confusion. And we need to make it convenient. We need to remove barriers to vaccines. And you've been hearing a lot about this in the news, I'm sure. There's a lot of discussion about all of these issues. Communication is a tool. So we asked in our data, could flu shot willingness maybe provide a head start for getting the vaccine when it became available? Back in June and July, when we did this survey, we couldn't really ask them about something that was real. It was just something that was hypothetical. But we know from a lot of previous research that your previous behavior often predicts your future behavior. So if you voted in the previous election, you're more likely to vote in the next election. It's not a one-to-one relationship. There are a lot of other things that get involved, but we thought maybe that could provide a head start, and we could look at that, and then we could look at the role of information in trying to move people towards willingness to get the COVID-19 vaccine. You can see here the total of people in our sample who were willing to get the vaccine back in June and July of last year was around 56%. For those who had gotten a flu shot, it was higher. It was more, almost 64%. And for those who had not gotten a flu shot, it was a little bit lower. It was about 47%. So yes, if you were willing to get a flu vaccine, that did give you a little bit of a head start on your willingness to get the COVID-19 vaccine, but it wasn't enough. The good news for the United States is that we have been near the top of countries who do have people getting flu shots. We were among the top of 50 countries that had been analyzed back in 2000 for how many people per thousand were getting the flu shot. You can see here we're number 2. So a decent head start. So here's some results from our survey. What we did, this was correlational data from a single point in time, but we were still trying to predict something. We were still trying to look at, if you have knowledge, are you going to be more likely to get the vaccine? If you think experts are useful, like the government entities I mentioned, are you more likely to get the vaccine? And what is the role of media literacy? So we looked at all of this in a structural model, and I'd like to acknowledge Bruce Austin, who did the analysis for this. And what we found was that knowledge was not enough. You can see that there's a line that's pointing from knowledge to vaccine intentions. There's also an interaction between knowledge and whether people got that flu shot in the past. What we found was that knowledge actually it had a small effect. And in fact, with all things controlled in the model, all other things remaining equal, knowledge actually was having a negative effect on vaccine intentions, a negative association, I should say. For people who got a flu shot or didn't get a flu shot, this also made a difference, but it was that interaction between knowledge and the flu shot that was really making something happen here. And I'll show you what that looked like in a second. Because it's a little bit complicated to get your mind around. The usefulness of experts was our biggest predictor actually in this model. If you were ready to trust the experts, you were trusting that the vaccine might be worth considering doing in the future. And media literacy was important. Media literacy for source essentially gets you going, thinking about whether that message is something that you can believe or not. Then you can look at the content of what's in the message and start looking at that more critically. So you can see media literacy for source associated with media literacy for content, which then associated with people's willingness, intentions to get the vaccine. So knowledge wasn't enough, previous behavior wasn't enough, trust of experts was key, and media literacy was helpful. This is looking at that interaction between knowledge and getting the flu shot. The solid line is people who got the flu shot, and the dotted line is people who did not get the flu shot. For those who got the flu shot, knowledge was there was a little bit of an association there. You're more likely to say you'll get the vaccine when it becomes available. But you can see that knowledge actually seemed like it was counterproductive for those who were not willing to get the flu shot. Now, people who didn't get the flu shot might have been not getting it because of convenience. They just didn't get around to it. They might not have been getting it because they were complacent. They didn't think it was important. They might not have been getting it because they were not trusting that it was something safe for them to do. All in all, that unwillingness to get the flu shot shapes the way you interpret information. And as a result, we tend to interpret information based on our existing beliefs and also sometimes our emotions and wishful thinking or fear. And you can see how in this case, knowledge in itself was not necessarily helpful. We do not make decisions based on knowledge alone. A lot of other things go into those decisions. So we need to think about that when we're thinking about people who are hesitant about getting the vaccine. And one thing to keep in mind also when we're thinking about our survey results, our knowledge questions were general questions about COVID-19 facts as we knew them back in June and July of 2020. They were not specific facts about the vaccine. So I think it's important for you to know that that's a little bit of a limitation of the association that we're presenting here. So back to disinformation campaigns more generally, and what are their implications? We know that disinformation campaigns especially target communities of color. We also know that communities of color are more hesitant overall about vaccines, and they have some reasons that are pretty logical for having some hesitancy there based on some things that have happened in the past. And so we looked at what are the differences between how people from communities of color are thinking about some of these things as opposed to white respondents. And we also looked at different communities individually, but our sample size got kind of small and we found very consistent results across different communities. And so we summarized them here. So what you can see is that for communities of color that are pictured in the more crimson here, they had somewhat less knowledge than the white population. They had more disinformation beliefs. They were less likely to intend to vote, and they were less likely to intend to get the vaccine. All of these things basically go together. If you think about how disinformation campaigns target communities of color, it's often to keep them from voting. It's often to keep them from becoming more powerful. And there are a lot of disinformation campaigns right now that are targeting about the vaccines, as you saw. So we need to take action together against disinformation. We need to do this stop and think activity about the source and the content of news and entertainment. Everything we see in the media, we should be thinking about it before we share it. It's good to look for more information. Skepticism is good. That means you're open to more information. You're still learning, just like we're all learning from each other today. Cynicism is not so good. That means you're being closed to information. You can't trust anyone. We don't want to be cynical. We do want to be skeptical. I want to encourage you to crowdsource against mis and disinformation and don't accidentally amplify it. Share real information and how to check it. The more we fill the media landscape with good information, the less room there is for misinformation and disinformation to take control. So a couple of things you can do. You can check out tinyeye.com and you can actually take a picture and see if it's been doctored, if it's been manipulated in any way. And you might want to do that before you share something. Another thing you can do is there on Google, there's a fact check explorer. So you can then do some fact checking before you share something. So there's a lot you can do, but those are two, I think, really, really big things, fairly easy things that you can do if you want to help with this crowdsourcing. It's something that can make a difference. We can do it. We can get those vaccines. We can encourage more people to get vaccines. And in the end, we can get this world to herd immunity and live our lives more like we would like to live our lives. So with that, I want to open it up for questions, and I want to thank you again for joining me today. And if you're interested in more information about the Edward R. Murrow Center for Media and Health Promotion Research, which I direct, our aim is to be a catalyst for collaboration for faculty and for students. My contact information is on this slide. Thank you so much.
Thank you so much, Erica, for that fantastic presentation. That was fascinating. It was scary. I think it was everything. Oh my goodness, that is just so interesting, so timely. I love that you even just started with covering disinformation versus misinformation. I had never heard that before. Very, very different, and goodness, just really important to know, and all of those tips that you shared too. That's so great. We do have we have some questions that came in either over YouTube or directly that were messaged to us. So one of these questions was about, even though you didn't look at any of the, let's say, anti-mask campaigns, do you think that, kind of the similar, you'd find like that similar model, like the structural equation model that you showed, you find a similar model with media literacy and things like that, similar than what you found for COVID vaccine intention?
Thank you for that question. Actually, we did look at that in our surveys. And we have a publication coming out shortly in the Journal of Health Communication, if people would like to see all the details on that. We did a structural model, and we looked at usefulness of expert sources. We looked at media literacy. We also looked at something called science media literacy. So a more specific form of media literacy that you can apply to testing information about science in particular. And then we looked at people's expectations about whether, if they wore masks and so on, if that was actually going to make a difference. We looked at their efficacy for doing that. We looked at their willingness to do that. And then we actually asked them if they were doing it. And what we found was that media literacy associated with science media literacy together, along with usefulness of experts, that predicted people's knowledge. Knowledge wasn't enough, just like in this vaccine model, knowledge was not enough to predict behavior. What we found was that knowledge, along with people's expectancies, the if-then beliefs that go along with, if I wear a mask, it will protect me, it will protect my neighbors. Those beliefs were really important and predicted people's willingness to do these protected behaviors, and then that predicted their actual behaviors. One of the things that's important for us to keep in mind is people express their intentions to do things and they don't always follow through. Just like the World Health Organization said, we don't always have the time, or we might forget, or it might not be convenient. Also, sometimes there's social pressure involved. And that's why sometimes it's appropriate to ask people about their willingness to do something, not just their intentions. And certainly around these COVID-19 protected behaviors like wearing a mask and social distancing, there have been tremendous social ramifications around all of those. And that's why we asked about people's willingness. So a combination of media literacy and trust of these experts led to knowledge and people's expectations about whether doing these things would work, which then led to their willingness to do them and their actual reports of doing them.
Great. Thank you, Erica. That's really interesting what you bring up about intention. And if something isn't very easy to do, especially when it comes to getting that COVID-19 vaccine, we see a lot of people that might have been on the fence and then opting not to have to go through the hassle of using Face Finder and scheduling and all of that. Luckily, the vaccine is becoming more and more available, and it looks like our tier system will be no longer in a couple of weeks here. So that should open that up. But that's interesting. Intention, just plays some role, but certainly is not, doesn't, 100% predict behavior. I want to move to knowledge. You said something in your presentation, knowledge was counterproductive. Oh, that was painful. As a scientist, as a researcher, I'm sure for all of our viewers out there, predominantly in the health sciences, you have pharmacy and nursing and medical researchers. And I think, our key tool that we go to is knowledge right away. We think, gosh, if we could just give enough knowledge to the general public, surely they'd make these healthy behaviors. Can you talk a little bit about that and maybe any advice you would have to researchers and scientists?
Sure. Yeah, it is a tough message to share, but knowledge is a good thing. It really is. And keep in mind that association that we showed in our results was with everything else controlled, and also in interaction with people's previous behavior. And so the thing to remember about knowledge is that it doesn't exist in a vacuum. And so people are interpreting information on the basis of what they've done before, what they know, what they think they know, their fears and their hopes, and what their neighbors are saying, and what their parents are saying, and what their children are saying, their friends. And so we have to remember that there's a lot of emotion that goes into decision making in addition to the information. And we need to make sure the information is there, but we can't share it in isolation and think that it's going to be enough.
Sure, great, thank you. So let's talk a little bit more about the specific, your topic here, media literacy. You talk about the importance of media literacy. How do you know if it really predicted anything when you're looking at cross-sectional surveys? Can you, expand a little bit on that? Are you just showing associations? Can you maybe hypothesize what it would look like longitudinally?
Yeah, that's a really important issue. This was just cross-sectional data. So anything that we're looking at things, the way things associate, and we are theorizing and testing our theories the best we can in cross-sectional data for associations that might represent a process. The way we can really test those, of course, is in some kind of an experiment and over time. Those kinds of studies are being done and have been done. I've been involved in some of them in which we've looked at with children as young as 3rd grade. If you do a media literacy kind of intervention, give them those tools, do they help in the future, not just right now? And we have seen that it works. We've seen that in a number of different studies looking at tobacco use, looking at alcohol use, looking at sexual health and decision-making around sex, looking at dietary behaviors and nutrition and how families make decisions around that. So we've done experiments, we meaning me and my research team, but also others around the country and the globe have done studies around all of these issues, some of which have been experiments. So we can be pretty confident that the relationships that we tested in our survey are real, but the associations that we show in that particular survey, we do have to be careful to make sure that we're not overstating our case from that one set of data.
Great, thank you. Thanks for explaining that in more detail. So continuing on with media literacy, it looked like your assessment for media literacy was self-report. How do we know, is there an objective way to measure that? Is it subjective? How does that play into your research?
Yes, a lot of people are very confident about things they can do. It's a little bit like the intentions issue. We think we're really good at using the media. We think we're really good at a lot of things. We aren't necessarily as good at those things as we think that we are. So we can have what's called efficacy, which is not the same thing as actually having skills. That's true with media literacy as well. And we measured information efficacy, people's confidence, and it's associated with media literacy, but it's not the same thing. And when we're looking at people's self-reports of what they do for media literacy, we're getting that a little bit of that response bias, and we recognize that. One thing that some people do in their studies is they have people actually analyze messages, and that way you can see, are they doing what they said they could do? Are they really doing it? And there aren't as many studies that are able to do that. And so we need the best we can get from self-reports, but there are some studies that have done it, and we do get consistent results.
Oh, wow. That is fascinating. That's really fascinating. We had a question just come in from one of our viewers here. Was age stratified? Was it a stratified variable in your studies?
We asked age by age group. So, 20s and 30s and 40s and so on. And we did analyze that. And in some cases, we would find associations between age groups and certain things. And we did control for demographics in that structural model that we showed. A lot of times age was not a really big predictor of things. We found that these other informational kinds of issues were bigger predictors, but it does depend, obviously, on what topic you're examining. So, older people knew and know that they are at more risk for COVID-19. And you do see that, that evidence in our sample. But in terms of the way people were making decisions, it was these other things. The decision-making process was not really affected as much by age. And so it was an important variable in the study, but it didn't actually affect people's decision-making processes all that much.
That is so interesting, especially when you think of something like COVID-19, where, it disparately, affects by age groups, and you have, age bands that are much more high risk, and then to know that they're maybe targeted for disinformation, that is, oh, so troubling, so difficult, and I think really highlights how critical your work is and this presentation. So speaking of some of that disinformation and misinformation, you shared a slide from the World Health Organization, and it had some surprising things in there, things like shoes or holding your breath and mosquitoes, things like that. Where did those topics come from? It makes sense that there'd be this misinformation and disinformation about COVID-19, but what about some of these other topics?
Yeah, some of us haven't actually seen misinformation on things like the mosquitoes, but there was a lot that was circulating, especially back in those early days of the pandemic, where people were trying to figure out, okay, what's going to put me more at risk? And a lot of rumors got going. Rumors about whether you had to leave your packages that were delivered to you outside for several days because there might be something contaminated on them. We started doing that stuff too. But so the World Health Organization looked at these kinds of things that were circulating, and they saw that there were rumors circulating about whether you needed to take your shoes off, whether you needed to, whether mosquitoes were spreading the virus, because mosquitoes can spread certain things. And they realized that they needed to try to get ahead of that kind of misinformation. And that's why they developed their public service announcements.
Oh, wow. Yeah, it seems like really early on, I think everyone was grasping at any type of information to try to protect themselves. Wow. Okay. Oh, that is really interesting. We're coming up towards the end of our hour here, unfortunately, but I do want to ask just one more question here. If people want to know more about how to work with you and your team, we have a lot of health researchers and scientists. This is, I think, the potential for collaboration with the College of Communication is just huge and seems so fantastic. How should they get a hold of you to contact you if they want to work with you on any of the work that is relevant in their area?
Well, thank you for that question. And thanks to everyone who's been watching and listening. It's such a privilege to be able to share what we're doing with you. And it's been such an honor to be able to collaborate with people from other colleges, the College of Education and the College of Medicine. There's so much we can do together that is more powerful than what we can do on our own. And of course, coming from the College of Communication, I think communication is the center of everything. The Murrow Center for Media and Health Promotion Research is really focused on helping people collaborate around this issue and how we can be helpful to promote healthy decision-making and wellness in every way you can think about it. We're on the website. If you go to the Murrow College, you go to, you can look for Murrow Minds, M-I-N-D-S, on the Murrow website, and you can get to the Murrow Center for Media and Health Promotion Research there to see who we are, what we do. You're welcome to email me. You're also, if you're interested in studying some of these issues, you can contact our graduate studies staff, and they'll be very happy to work with you about how you might be able to take courses. We have some online programs as well as in-person programs that will really be in person again in the fall.
Great. Thank you so much, Erica. This has been a fantastic hour to spend with you. Speaking of in-person, typically we have our keynote in person on our campus, but I think this actually presents a fantastic opportunity. We have viewers, from all over right now that were able to join us this afternoon, but we'll also be sharing your presentation. It will be emailed out to everybody that registered for the Inland Northwest Research Symposium. We will keep it on our website. And so many people will be able to watch this than had we just had it in person, although it sure would have been nice to see you in person and have lunch together. Thank you so much. I know your piece about communication, I think all of the clinicians watching, I think would also agree. I mean, with the focus on patient communication, but still all of these tools, these collaborations that you shared with us, the potential is so great. So thank you so much. A special thank you for you and your research team for sharing your research with us. I want to thank everyone who is watching as well. We will continue the Inland Northwest Research Symposium with our poster presentations that have been going on all day. We'll be coming back at 1:30 on the Zoom link, so make sure you check your Inland Northwest Research Symposium registration email for that link. Thank you all for joining us. Thank you again, Dr. Erica Austin, for being our keynote, and have a wonderful day, everyone. Thank you.